And it's a pleasure to be with everyone today. I would like to briefly give a sense of the genesis of this article so that everyone has a context. I am on the ACEP, the American College of Emergency Physicians Ethics Committee, and last year I was the lead on the subcommittee that wanted to address the Board of Directors' request to develop a curricular content to explain the ethics of real-time EMS directions. So this was the genesis of that work, and I have to thank all of my co-authors, as you saw listed in the pre-hospital and disaster medicine article heading. So what I'd like to do today is walk through the article and then address what questions may have arisen after folks have read it. So just to make sure I have the right audience, I'm going to start by reviewing who I think we were trying to reach with this article, and that is anyone who is either on the giving or receiving end of online medical control. So this, might include the EMS providers who are delivering pre-hospital care, or it may also include the online medical control physicians, advanced practice providers, and nurses who are answering the radio. And importantly, it also involves the EMS medicine fellows and fellowship directors and paramedic program directors who are trying to instill this in the curriculum so that we can learn it didactically before practicing it in real life. So why are we doing this? Well, there are 14.4% of paramedic responses involve ethical dilemmas, and these ethical dilemmas are really challenging in the pre-hospital environment because there's limited patient information. There's important decisions that need to be made rapidly, and sometimes these decisions are made in quite austere environments. My first disclaimer here is that medical care in the pre-hospital setting is much more challenging than the environment of the emergency department. And my primary role as an emergency physician and as a medical director is in the setting of the emergency department. I do not have any medical director contracts with EMS agencies, so I am in the comforts of the emergency department. And so I do respect all of the hard work and sometimes nearly impossible situations that are encountered in the pre-hospital setting. My other disclaimer is that this article really is intended to focus on content of a curriculum. However, it is not a curriculum. It lacks, some of the educational philosophy that tends to be involved with curriculum, with educational strategies, subject matter sequencing, learning outcomes, and really there is no quiz at the end of this. I think everyone will be happy about that. There is no assessment tool. So let's get into the content. It's important whenever we talk about ethical dilemmas to review the principles, which, at this point I think everyone's familiar with, and some of the theories behind them. I think everyone is familiar with the concept of autonomy and respect for it, beneficence, non-maleficence, and justice. These all play in to our decision making, but how we weight each principle does depend on the situation. I think the most prevailing theory when it comes to guiding ethical dilemma management in the pre-hospital setting is focusing on the duty or obligation to treat. And so this means that we have to have the proper personnel and equipment to handle pre-hospital emergencies. We have to be non-discriminatory. In other words, it's listed here later that medical priority has to take the first consideration as opposed to social priority. And then Refusal of treatment has to be respected in the proper setting with the patient who has capacity to refuse, and we have to have a sense of taking every situation novelly. Even if we have principles to guide us, every situation is unique, and sometimes we must improvise and not judge others harshly for making the best decision they could in the time. Finally, we have to balance that duty to treat with the duty for self-preservation and keeping in mind the safety of the healthcare professionals involved. So this comes from Dr. Isaacson, who is one of the co-authors on this article from his textbook, which has now gone to revision. He offers us this rapid approach to emergency ethical problems, and I find it highly useful both in the pre-hospital and emergency department settings. Essentially, there are 3 steps. First, if there's already a rule, follow it. If there's no rule, then you must ask, is there time to consider our options? And if there is time and we can delay and think about our best options, then we should. But often there's no rule and there's not any time and we have to make a decision. Well, then he splits it into 3 tests, if you will. And these are thought tests. They're not tests that require any pen and paper. They just require a second to think. And that is the golden rule or a variant of that, the platinum rule, where, what would you want done in the same circumstance? The universality test, which is what would others with the same knowledge and experience do in the same circumstance? And then the interpersonal justifiability test. How would you feel if your decisions were described to peers of yours? And even adding in the concept of how would people on social media, for example, today think about what you're saying? Okay, so now that we have a sense of the principles and theories behind how we're going to approach these ethical dilemmas, let's go ahead and dig into 5 common ethical dilemmas experienced in the pre-hospital setting. And I would argue these are really 5 core topics that should be covered in any paramedic training or online medical control training. So protecting privacy and confidentiality, decision-making capacity, refusal of treatment, withholding of treatment, and termination of resuscitation. So first, protecting privacy and confidentiality. This has become especially in vogue because of new technological advances since some of the articles that we cited in our article were published. But we need to divide this into 3 categories. So one is physical privacy. So that means that if we are responding to an emergency in the pre-hospital setting and a patient is exposed indecently and there's an opportunity to shield them from public bystanders, then we ought to do so. Another is decisional privacy, and that gets to some of the decision-making capacity that we'll go through later. But really, a patient's decision, if they do have autonomy to make decisions, ought to be their own and should be maintained as confidential as possible. And then the third is the most complicated and really changing and evolving as we modernize technology, and that is information privacy. Obviously, there are exceptions to this. Certain wounds or injuries require reporting when there's an active crime, whether the patient whom you're taking care of is a suspect, a victim, or of the crime, or is actually recently expired and involved in a suspicious death, or is suspected of a crime. All these reasons may be reasons to share information with law enforcement officials. But otherwise, in the U.S., we have a HIPAA law, and there are similar laws across the world where the privacy personal health information is very important. And what we've seen is that that protected health information has not been as well protected as we would like, in part because smartphones are ubiquitous. Photographs and videos have been taken by healthcare personnel in all settings, but in the pre-hospital setting, really, photographs and videos are not for personal use. There should be an effort to exclude license plates or any other identifying information if you are recording photographs or video for educational purposes. And if you are recording for educational or research purposes, consent is required. There are certain situations where consent can be obtained after the patient has been stabilized. Certainly, if it's infeasible at the time. However, that is essential before dissemination of any of that information, and also that information needs to be deleted from any personal use recording devices once it's been uploaded into protected servers. So second issue is decision-making capacity. I'm going to share with you a few different ways to think about this, some of which were not included in the article. But the one that was provided by our co-author, Dr. Verrier. And she focused on the assessment of the 4 Ps. So a patient needs to be able to paraphrase, show that they're able to process the information, make a plan showing insight, and then put together all the information. I find that this sometimes leaves people feeling like these are overlapping. So I've offered a couple other ways to think about this. One is the table that was included in our article previously, again from Dr. Isterson's textbook, that patients should have knowledge of the options, awareness of the consequences of each option, and appreciate the personal costs and benefits of options. And the patient really needs to make a choice. I'm not sure that this satisfies everyone's appetite. So what I've been pushing for is a fairly simplistic model that I call RVU. And in the U.S., RVU is an acronym for relative value units, and is used in the process of our compensation programs. However, in this setting, I'm talking about reasoning, value system, and understanding. In other words, the patient has to show sound reasoning. Whatever choice they make needs to be consistent with their value system. And before they make that choice, they have to understand the risk and benefits of their decision. And I think this model works best for me. However, whichever model helps you sort through whether or not a patient has decision-making capacity is the one that you should use. Whichever model you do use, these are a list of red flags that should make you question decision-making capacity. The most common error I see with regards to decision-making capacity is that it was not questioned. Some of you, as Andrew mentioned in the introduction, know that I've been involved with discharging patients against medical advice research. And one of the things that we know is that we actually in the US document that very well. However, we document their decision-making capacity to make that decision very poorly. So if any of these conditions are present, intoxication, confusion, if there's any major trauma, if there's some kind of fluidity to their decision-making capacity, in that they wax and wane in their lucidity or in their commitment to one decision. In other words, if they're indecisive, if there's any significant emotional upset or signs of psychosis or any distortion of reality, or or fear of some kind of repercussions from their decision, these are all reasons to question their capacity formally. So as a segue, our third topic of refusal of treatment, really does require that someone has decision-making capacity. And if we have time, I do have some radio call transmissions that I can share with you to reveal the typical online medical control approach to supporting our pre-hospital providers when a patient is refusing treatment. And the linchpin of it is really whether or not the patient has decision-making capacity. However, even when a patient has decision-making capacity, that doesn't mean that your efforts are done with regards to refusal of treatment. So if you are called to a patient in the pre-hospital setting and they are refusing treatment, certainly if they're not refusing transport, but just simply refusing treatment, there's no reason to delay transport while you try to persuade them to accept treatment. Ways that you can persuade include establishing a rapport, talking with the patient, which really involves not just you talking with the patient, but involving bystanders that may be family members or friends, involving the online medical control, and really anyone who can connect with the patient to explain to them in a way that they understand. Certainly you want to offer their alternatives of treatment, and sometimes there's some bargaining and negotiating that occurs there that may be suboptimal, but better than no treatment. And again, medical command can be helpful sometimes with negotiating with the patient. And ultimately, if the patient does not have decision-making capacity and they're refusing treatment, and they are intoxicated or delirious or psychotic, then you may need to resort to physical restraints and sedating medications in effort to protect them from themselves, since they lack autonomy, and then you are really focusing on the beneficence principle more so. Fourth topic is withholding of treatment. And this may sound like the opposite of refusal of treatment, where a pre-hospital provider is recommending a treatment and the patient is refusing it. In this case, the patient is requesting it and the pre-hospital provider is withholding it. An important principle here is what goes into in the U.S. Our law, Emergency Medical Treatment and Active Labor Act, which has similar like laws across the world, that defends the layperson definition of a medical emergency. And what that means is that when a layperson or a common person, any person, accesses emergency medical care, they may or may not have an emergency in the eyes of the healthcare professionals. However, we need to defend that definition of an emergency, or else we may suffer laypersons not accessing healthcare when they need it. So I don't think it's the place, and my co-authors agree that pre-hospital providers should not refuse or delay care or transport to patients they perceive to have a non-emergent condition, or to be using ambulance services for secondary reasons. The caveat, and this was not in the article, and as I read it critically, I think maybe a limitation is the expansion of community paramedicine throughout the U.S. and other countries is certainly taking hold and quite proper with the appropriate patient, and there are certainly some patients who can be managed pre-hospital-wise. That being said, when there really is a difference of opinion between the patient requesting treatment and the pre-hospital provider tempted to withhold it, the leaning ethically is to the patient, because they are the ones that have the layperson definition of a medical emergency on their side. Obviously, again, mentioned before, but important to reiterate is that a pre-hospital provider may withhold treatment if it's unsafe. There are walkway impediments. I'm talking with you today from Syracuse, New York. We have quite brutal winters, and there are some times when accessing patients isn't immediately safe. There are confined spaces, and that can make it challenging. Obviously, motor vehicle crashes, and then we have quite a few references about the interpersonal violence that we've seen developing against pre-hospital providers, whether it be physical, verbal, or sexual, and certainly all of these reasons are reasons to withhold treatment until the scene or the patient can be made safe. Provided here from a wilderness medicine textbook is a figure that we use to show that the safety factors are paramount, and before you can get to the medical indications for rendering treatment or considering the patient's autonomy and respect for it in whether or not they have decision-making capacity to refuse such treatment, really you need to make sure everything's safe. Withholding of resuscitation is a subset of this withholding of treatment. The American Heart Association offers us a criteria list of 4 situations where we may in fact withhold resuscitation. In the U.S., this is quite a common situation with 350,000 out-of-hospital cardiac arrests per year that are assessed by our emergency medical system. Unequivocal signs of irreversible death, scenes that may threaten safety, valid advance directives, and if a surrogate decision maker expresses clearly the patient's preference for do not resuscitate or DNR, these are all good reasons to withhold resuscitation. Ethically speaking, withholding resuscitation and termination of resuscitation are slightly different for some and quite similar for others. So I am addressing them separately, and we chose to as co-authors to do so. They segue into each other, however. Termination of resuscitation, this gets back to Dr. Iserson's 3-step approach to making rapid decisions to ethical dilemmas. So if there are rules, if there is a protocol, then it's best to follow it. And in fact, one other criticism I have of our own article, looking at it in preparation for this webinar, was that one of the co-authors said that only 81% of EMS systems have a protocol. This was Jesse Bassford, and he was quite upset about that. I think the point is more so that 81% of EMS systems have a protocol and therefore should be followed. Obviously, it would be good to get the rest of the EMS systems having a protocol for termination resuscitation, because this can be a ethical dilemma that if a decision is not made, leaves a patient and their family and their loved ones suffering through a prolonged attempt at resuscitation that was either not desirable for the patient or their family or for the system. So, termination of resuscitation is appropriate for patients that, after resuscitation has begun, it's then uncovered that there are valid advance directives, whether it be a DNR or physician order for life-sustaining treatment. And we've really been trying to not just develop our protocols for TOR, but also to develop our access to PULSed, or as we know it here in New York State, MULSed, and some states like Pennsylvania have developed ePULSed, which is an electronic database, and that really has been catching on state by state in the U.S. And the more access there is to a patient's preferences as documenting in a physician's order of life-sustaining treatment, will help to mitigate that difficulty of interpretation rapidly when pre-hospital care is accessed. So, in summary, hitting upon some of these issues, again, I think it's important to respect patients' privacy when possible. Quite important to honor requests for refusal of treatment if the patient has decision-making capacity. And I hope I've given you some tools to assess that. Although I will say that there is much more that could be said, and I'd be happy to share more about that. And when a patient doesn't have decision-making capacity, it's important to defer to a surrogate decision maker if there is someone qualified to do so. And then finally, we as emergency physicians, as pre-hospital providers, should only withhold treatment and terminate resuscitation when appropriate. However, we ought to do it when it is appropriate. So with that, I think I will pause here to allow Andrew to field some questions from all of you.
Thanks, thanks, Dr. Brenner. So at this point in the webinar, we welcome questions from the remote audience. You can either send questions using the question feature, which is the little question mark icon in the panel, or even better, if you want to ask a question directly, click on the hand icon, and then I can unmute your microphone, and then you can ask a question directly. But I had a question just referring to some of the last few slides of the presentation. You had mentioned that 19% of EMS systems in the United States don't have termination of resuscitation protocols in place. Is my understanding of that correct?
Yes.
So I know this is kind of a layperson question. So what do those individuals do in that pre-hospital setting to make those calls on termination of resuscitation if they don't have protocols in place? It's really up to the individual to make the best determination.
Yes. So that statistic is from a 2012 article in the Resuscitation Journal. So I'm hoping that statistic has actually improved since then. However, the default is for pre-hospital providers to contact their online medical control and to handle the termination of resuscitation request in a case-by-case basis. And I think that only serves to augment the role of instilling these sorts of topics into a curriculum so that those who are providing that online medical control or those who are providing the pre-hospital care can have a sense of what they should consider. For example, the AHA considerations for withholding resuscitation when they're considering termination of resuscitation. A protocol saves you a radio call, but it may actually lead to the same appropriate decision, whether you have one or not.
Okay. I had another question. Again, this is sort of coming from a layperson. I don't have a medical background myself. But when you have someone who's refusing treatment, who clearly needs treatment, is there a situation where the pre-hospital provider can sort of override the wishes of the patient and provide treatment when it's clear that if they don't get treatment, they could be in a life-threatening situation?
Oh, well, absolutely. Again, so a patient who lacks the decision-making capacity is clearly intoxicated or delirious or psychotic. The pre-hospital provider's ethical duty is to take care of that patient in spite of themselves.
And even if they're refusing treatment and they appear to be kind of sound mind and could be making informed decisions?
Well, the only exception I can think to that would be in a situation where the patient may be a risk to others, even if they are in fact having decision-making capacity and also refusing treatment. There may be a situation where the consideration of other bystanders, whether it's involving an infectious disease or a threat of violence, where the pre-hospital providers may be working in collaboration with law enforcement officials to stabilize the overall situation. But really, I think of all the principles, there's a reason they're in the order they are. The respect for autonomy is paramount ethically, and if someone understands the risk they're taking for themselves, then their request to refuse treatment should be honored. It preserves the relationship long term with the healthcare system, so that we all can be trusted to um, um, offer and recommend our best treatment, but accept a refusal.
Okay, well, thanks. That's very interesting. So I'm not seeing a lot of questions here. Please feel free, folks in the remote audience, to ask a question. That's one of the objectives of this, is to stimulate a discussion amongst the audience and the presenter. But if everyone's feeling a bit shy and timid, then I suppose
well, why don't I do this, Andrew? Since I hinted at them, and I think it gets to your second question. Why don't I share the radio call as just an example of someone who was unable to refuse treatment, and then another radio call where someone's refusal was acceptable.
Okay, sounds good.
So this first radio call is an example of a refusal of treatment that was not reasonable.
For some reason, we're not getting any audio on that.
Oh, is that right?
Yeah.
Valium and some prescription Xanax, and the officer said that she was stumbling around the mall today. When we got to her, all of her vitals were within normal limits. She was able to tell us who she was, where she was, what she took, and what was going on. So she was conscious of ignoring it times 4. She was refusing transport to any hospital, but the police are demanding that she go because this is a medical emergency, they're saying. So we just were inquiring as to what you would recommend.
She sounds intoxicated, so she should not refuse, and she should come to the hospital.
What was that?
It sounds like she is intoxicated and should come to the hospital and does not have the capacity to make a good medical decision for her.
All right. I will do that then. Thank you very much. Bye-bye.
So were you able to hear that?
Yeah.
Great.
Did you copy?
So I will.
Resource affirmative. She hung up.
I will now share an example of a patient whose refusal of treatment was acceptable. And in that first case, it was someone who was intoxicated.
Resource, come out for no on a phone patch. Resource, come out for no on a phone patch.
Dr. Schwartz, resource, go ahead.
Resource, paramedic cook with no ambulance helmet. How do you copy?
Loud and clear.
Resource, I'm on scene with a 67 female who complained of a fast heart rate no history of cardiac, but does have a history of anxiety. Sometimes it just comes on, and sometimes she feels it coming on. This time she didn't feel it coming on. Initial vital signs when we arrived on scene: heart rate 124 and regular, blood pressure 156 over 98, respiration 20 regular. Put her on the monitor. She showed to be sinus attacks. The 12 lead EKGs just to be sure everything was okay. It looked good. Blood glucose is 226. She had a whole bunch of sleep today, no diabetic history. Again, no heart history as well. This time she's refusing to go to the hospital. Her heart rate has come down a little bit to 114 in regular. Explained to her the risk consequences of possible heart attack, cardiac arrest, including death, and she's aware of those and accepts those and understands everything that is presented to her.
Copy that, Paramedic Cook. Do you have a question in there?
The only request is right now is if you feel comfortable with her refusing. I don't feel comfortable she's going to be with her husband at this point and contact her doctor.
Yes, sir. If you feel that she has the capacity to make that decision and understands the consequences up to and including death, I'm fine with that refusal.
Okay. Can I get your name again, Doc?
Esteban Sam, PA.
Okay, so I'll give some tangible examples of acceptable situations for refusing treatment.
Okay, so we did have one question come over the chat feature from Elaine Miranda, and she asks, in low resource settings, how do professionals base the decision about who should be treated first?
That is a fantastic question, Elaine. Thank you for that. One of the situations that we discussed as a subcommittee in writing this article was that exact situation, where in an austere environment, there's only resources enough for one transport, and there's more than one patient. And to refer back to my slides and our article, the emphasis has to be on the medical clinical priority. So whoever is sickest deserves the transport and the treatment first. That can be difficult to discern sometimes, and obviously it would be preferable to try to address resource limited situations with more resources, knowing, in general or even specifically what resources are required on certain times of day and certain even seasons of the year. But sometimes these decisions are unavoidable, and again, I would emphasize that the medical priority be considered first.